Ma'am, just,
Yeah,
ma'am, I'll...
okay, thank you. Good evening. Welcome you all in today's webinar, The Glaucoma Revisited. It is a series webinar actually. Today we will have our first session, The Glaucoma Diagnostics. The session will cover the most salient and the highlighted points needed for all of us for the basic diagnosis of glaucoma. We have with us today our esteemed national faculties who will help us to recapitulate those important basic concepts. We are fortunate to have them all with us today. As a customary, let me introduce myself. Hitendra, I like to have the slide share. Dr. Moitri Das?
Yes, ma'am.
Yeah, please. Hello. So I have done my fellowship in glaucoma from Shankar Netralaya and now practicing in Eye Foundation and Research Center for more than 2 decades. And I'll be moderating the session.
Ma'am, I'm sharing the slides.
Yeah.
You
I have already spoken about myself. I was the East Zone representative of Glaucoma Society of India from 2002 to 2004 and was Glaucoma India Education Program Coordinator under Glaucoma Society of India from 2004 to 2006. And today I'll be moderating the session, and I'll have Dr. Arijit Mitro as my co-moderator. Let me say a few words about Dr. Arijit. He's a very young and dynamic academician. So I am fortunate to introduce him here. He is the glaucoma and cataract consultant in Disha Eye Hospital, Barakpur. He is a former glaucoma and cataract consultant at Arvind Eye Hospital, Tirunelveli. He has done a long-term glaucoma fellowship under Dr. Ramakrishnan. He had secured the highest marks and had earned the Kunja Kusum Scholarship for all the 3 MBBS examinations from NRS Medical College, Kolkata. It's my institute also. He has won the gold medal in the postgraduate examinations held under WPUHS in 2007 and has won the best paper in glaucoma at AIOC 2014. He has won the DB Chandra Award for the best paper in glaucoma at AIOC 2014 and has more than 30 publications in peer-reviewed journals and has written chapters for 7 books. He has been the chief instructor in ICs at state, national, and international levels and has presented numerous papers, posters, and videos at state, national, international forums. I am fortunate to have Arijit as my co-moderator. May I request Arijit to start the session and call the first speaker. Dr. Arijit, please.
Yeah. Thank you so much, ma'am, for those kind words. It's a pleasure to be a part of this program. And it gives me great pleasure to introduce Dr. Shashmita Das as one of the first speakers for this program. Shashmita is one of the young and dynamic ophthalmologists, and we all know her. She's been around for quite some time, even though she's so young. She is an academician, an ophthalmologist, and an eye surgeon by choice. She currently works at Core Vision Eye Hospital, Bhubaneswar, as a senior consultant ophthalmologist. She did a post-graduation DNB in ophthalmology from the esteemed Shankara Netralaya, Chennai in 2008. Her special interest in glaucoma took her to Aravind Eye Hospital for a long-term fellowship in glaucoma from 2011 to 2013. She has worked as a senior resident at JPM Rotary Eye Hospital from 2010 to 2011. Later, she worked as a glaucoma consultant at AMRI Hospitals, Bhubaneswar from 2013 to 2016 before reaching her final destination at Core Vision Eye Hospital. She has also worked in Community Eye Hospital as a visiting glaucoma specialist and was a part of many community outreach programs for general awareness on glaucoma. She has presented many papers in state and national conferences, as well as taken part in CME to teach postgraduates. She has a keen interest in congenital glaucomas and secondary glaucomas. So it gives me a great pleasure to start this program with her talk. And her talk is going to be on Iop and glaucoma. Now, when we think of glaucoma, we think of IOP. And when we think of IOP, we think of glaucoma. So let's see what Shashmita has to say about this particular topic. Over to you, Shashmita.
Thank you, sir. Thank you so much for your kind introduction. Maybe I don't deserve that much.
You deserve every bit of it.
I'll start by sharing my screen. Yeah. Thank you, Maitri ma'am, for this opportunity. So today I'll start the session with the diagnostics of glaucoma. That is, first and foremost, is IOP and glaucoma. So coming to the concept of IOP, the definition in a very simple terms is intraocular pressure, which refers to the pressure exerted by intraocular contents on the eye coat of the eyeball, which is maintained by the equilibrium between the aqueous humor production, its outflow, and episcleral venous pressure. So we measure this IOP by process of tonometry, which is a process of estimating or measuring the IOP. Basically, the tension in the outer coat of eye is measured. So classification, coming to the classification of this tonometry is according to the fluid displacement theory, which has a low displacement and a high displacement, and according to the deformation of globe, which is contact, non-contact. In contact tonometry, we have indentation and applanation. In indentation, we have shears. In applanation, we have Goldman's and non-contact tonometry, and where both indentation and applanation works is tonopen and pneumotonometers. So what is the criteria for ideal tonometer? It should give us the accurate and reasonable IOP measurement, convenient to use, simple to calibrate, stable from day to day, easier to standardize, and free from any maintenance problems. So coming to a very obsolete one, shears, but it is basically for the benefit of our postgraduates to know the basic of the tonometer which was used in yesteryears. The principle was when the plunger indents the cornea, the baseline pressure, PO, is artificially raised to a new value, PT, where PO minus PT is the resistance of the eye to the displacement of the fluid. Now, the instrumentation, you can see a foot plate, which is on the cornea, and the plunger diameter is there 3 millimeter, and weights are there 5.5 gram. You have to add the weights of 7.5, 10, 15, and plunger movement is magnified by 20 times. So method is you make the patient supine, and there is it measures by corneal indentation, fix a target, and if the scale reading is less than 4, then use 7.5 gram weight. If it is less than 3, 10 gram weight. And you have to correlate with Frieden-Wald stable. Now, sources of error in this shears tonometry is based on the ocular rigidity. Increased rigidity causes false high IOP in hyperopias, long-standing glaucomas, vasoconstrictor therapies, and decreased rigidity, that is falsely low IOP in myopics, myotic therapy, on vasodilated therapy, post-RD surgeries, or intravitreal gases. Even cornea influences, that is steeper and thicker corneas, give falsely high IOP, and irregular corneal surface gives unreliable IOPs. Repeated measurements also cause decreased intraocular pressures. Now, very important, coming to applanation tonometer, which is our gold standard and works on the principle of variable force. And it was given by our Goldman's based on Imbert's fixed law, where the pressure within the sphere is equal to external force required for flattening divided by total area. P is equal to F by A, where you consider a sphere to be ideal. Ideal sphere should be spherical, it should be thin, it should be dry, but no surface is found to be ideal. So cornea does not meet the ideal surface. The formula was modified by F plus M by F P into A plus N, where N was the force pushing away the applandating surface, and M is the force created by the surface tension of the tear film. So instrumentation, if you see, that is connected to the slit lamp. There's a biprism, there's a feeder arm, you have a housing unit and an adjustable knob. The illumination unit should be coaxial, and it should touch the cornea after instilling the fluorescein staining. And the fluorescein semicircles are viewed through the biprism, and force against the cornea is adjusted until the inner edges overlap. So the sources of error in this applanation tonometry could be instrument related, that there could be a calibration error, which is a weight bar. 5 circles are engraved on the bar, middle corresponds to the drum position, and 0 to 6 on the either side. So sources of error could be tritine related. If there's too much of fluorescein, it could cause falsely high IOP, low IOP, and if it is very thin, it is called high IOP, and it should be optimum. The inner edges should meet. So corneal thickness, in thinner corneas, we get underestimation of IOP. In thicker corneas, there is overestimation. And in post-laser refractive surgery, there is underestimation of IOP in these eyes. So corrected estimation of IOP is very essential. So AT over the peripheral untreated cornea gives us more accurate estimate of IOP. So, against corneal curvature, the steeper corneas will overestimate the IOPs and flatter corneas underestimate the IOP. Even with the rule astigmatism, underestimation of 1 millimeter mercury has noted in every 4 diopters astigmatism. The irregular corneas also interferes with the accuracy. Now, at this point of time, talking about CCT is very important, where Goldman application tonometry is more accurate, most accurate for corneas of thickness about 520 microns. Thinner corneas will give falsely low reading and vice versa. So effect of CCT depends on the correction factor, which is very cumbersomely given as a large formula. We don't use it. So for the easier purpose, what we apply is every 100 micron change in thickness, 7 millimeter discrepancy in measurement can be done. So Oates study had confirmed the importance of this thin cornea in development of glaucoma in ocular hypertension. They said that 36% of CCT less than 555 microns developed glaucoma, and only 6% with CCT more than 588 developed glaucoma. So what is the advantage of GAT? It is a reference standard for IOP measurement, minimal disruption of corneal epithelium, compact and mounts easily on slit lamp, handheld models available for restricted patients like Perkins, mechanical device very reliable with little maintenance. But disadvantage is it can be only mounted on slit lamps. If patient is not able to be positioned on slit lamp, then you cannot take GAT. Easily influenced by external pressure, not as accurate with thick or thin corneas. Adjustment of calibration has to be done every 3 monthly. Coming to Perkins Terminometer, which is a handheld Goldman's type of tonometer and very useful in infants and children in supine position, is accurate in horizontal and vertical positions, and is an excellent tonometer to use in ORs for EUAs. The accuracy of tonometer is similar to that of GAT, with the mean difference between the two is 1 millimeter of mercury. It has also a good reliability. So application variable force, other tonometers are Mackay mark, which has a plunger connected to the spring, and transducer records the movement of the plunger. So the portable variant of this Mackay mark is the TonoPen. So TonoPen is the portable handheld Mackay mark battery operated, which has a strain gauge at the tip connected to the microprocessor and senses a force curve as above, and displays the pressure and standard deviation. It has a good correlation with Goldman's. So this in the picture, you can see the TonoPen, which is touching the cornea with a latex rubber sleeve, and this can be changed for every patient also. And the readings on the TonoPen comes as good, bad, and the coefficient of variance ranges from 5% to 20%, which is acceptable. And it is accurate for scarred and edematous corneas as post-operative patients, and it's very rapid, portable, compact, ideal for ward rounds, health fairs, and small children's. So it has a positive correlation in corneal thickness. It is least affected. Average of multiple readings are taken. And post-laser refractive surgery, peripheral measurements are more accurate. But it overestimates a low IOP and underestimates a high IOP. So accuracy is not reliable for routine office use. Now coming to non-contact tonometer. In non-contact tonometer, the jet air deforms the cornea, the transmitter directs the light at corneal apex, detector accepts the parallel coaxial rays, and the timer measures point of peak intensity, which is equal to timing of corneal flattening. So it has a unique advantage over other tonometers of not touching the eye other than with puff of air. It's accurate when compared with Goldman's. No anesthesia is required, no damage to corneal epithelium. IOP can be determined with a soft contact lens on or in irregular edematous cornea. However, it produces a very loud noise which alerts a patient. So measurement of NCT correlate rather with GAT, but studies have found that there is systematic overestimation by 0.12 to 0.58 millimeter of mercury. Now coming to rebound tonometer. Rebound tonometer IOP measurements near the corneal periphery correlate well with the readings done at the center, and compared with GAT, it slightly overestimates the IOP in some groups, with reporting a difference of as low as 0.6 and other groups reporting a difference as high as 7.7 millimeter of mercury. So probes are disposable between patients, so disinfection is not necessary. The disadvantage is that it can be only used in upright position. Probe falls out if the instrument is faced downwards. But newer model of eye care is usable in supine position. Now, there's something called continuous Iop monitoring. Why it is needed? Because intraocular pressure is a dynamic parameter with a circadian rhythm and spontaneous change. So Leonardi et al. Introduced a soft contact lenses, lens sensor with embedded strain gauges that measure the ocular dimensional changes. So it is something called triggerfish contact lens, and it can record the IOP in the outpatient setting for up to 24 hours, including during undisturbed sleep. So device was judged as to be very safe, but the main adverse effects being superficial corneal staining and conjunctival hyperemia occurring in half of the studied individuals. So main limitation is that output signal is provided in relative units of millivolts. How to convert it into millimeter of mercury was a challenge. So it was not used much. So coming to dynamic contour tonometry, the principle of contour matching, it is mounted on GAT, and it has a piezoresistive pressure sensor, measures IOP 100 times per second. It is direct and continuous, and data is transferred to the microprocessor based on control unit displaying the measurement. So this is dynamic control tonometry, which has the digital display of IOP and ocular pulse amplitude. This ocular pulse amplitude is basically the difference between the diastolic IOP and the systolic IOP. So this is how it is mounted on the GAT, and this is the waveforms which is formed, and you can see the systolic IOP and diastolic IOP, and in between that is the OPA. So there's something called home tonometry, as we know that glaucoma is a chronic disease and a lifelong monitoring of IOP is needed. There's something called eye care rebound tonometer, which is not the same eye care as we use in OPDs, and a ProView. The ProView, a patient, the picture of ProView is given here. The patient presses the device on the partially closed eyelid until they see the appearance of pressure phosphenes. So this is, so when nothing works, sometimes in some corneas, you cannot do any tonometry where tactile or digital tonometry has to be done. You ask the patient just to look with their eyes open down and palpate the upper tarsal palpebra and avoid palpating over the cornea, which will give a high reading. And it is used in corneal scars, irregular surfaces, or injuries. So at the end, we should know what is the systemic review of the agreement of tonometer with the Goldman's applanation tonometer. Well, so many tonometers are there in the market. So when compared to GAT, the NCT was the tonometer with the least amount of variability in IOP. Approximately 2/3 of measurement with NCT were estimated to be within 2 millimeter of GAT measurement. And second lowest variability was observed in handheld applanation tonometry like Perkins, with 59% of measurements within 2 millimeter. So at the end, the very important topic is disinfection of tonometers. In this COVID area, this topic has been widely discussed. So shiots we don't use, but we just can disinfect with disassembled and cleaned with alcohol, GAT with 2% bacillocet, and even they say that you can have in disposable prisms. How far it is feasible, I have no idea. So tonopen tip is covered with the single-use disposable sleeve. It can be recommended in this COVID era. And even rebound tonometers, disposable probes are there. So it is also ideal. And non-contact tonometer, chin and forehead rest needs to be cleaned with alcohol, but it was not recommended in this pandemic because of formation of some aerosolization, which was later refuted. Basically, you have to keep the cornea clean and dry. Don't put instill any eye drops so that it will form an aerosolization. And I think, thank you. Thanks for the attention.
Thank you so much, Shashmita, for that excellent, crisp presentation on IOP and glaucoma. So just some quick points, a quick question, because you yourself have worked at the community level. So what kind of tonometer would you prefer to use at the community level? And what is the tonometer that you would go for use in the hospital? Because you've mentioned a very good correlation between NCT and GAT. So would you measure patients with NCT and then go for GAT based on the NCT levels? So first question is about the community, and the second is about the hospital.
Yes, NCT, in community level, if we can carry the NCT machine over to the camps and all, small portable NCTs, then I think NCT would be fine. Otherwise, nowadays, even we can procure this eye care and we can do it in camps.
Okay.
And definitely in OPD level, I don't compromise with GAT. Even if we have eye care in our, both the models are there. But for my routine use of glaucoma patients, I do get in each and every patient.
Okay.
Dr. Shashmita, just unshare your screen.
Yeah, yes, ma'am.
Yeah.
Is it okay now? Yeah.
I have a question, Dr. Shashmita.
Yes.
So for the diagnosis part, how much it is important to diagnose a patient having glaucoma with increase in intraocular pressure? That could you just highlight that sometimes we get a lot of cases that where the intraocular pressure is not raised that way, but the patient is having glaucoma. So how much importance it should get whenever, even if we get normal intraocular pressure and have the patient having glaucoma?
See, ma'am, we all know that IOP is the only, we know that glaucoma is just the optic nerve neuropathy, but IOP is the only modifiable risk factor. So first and foremost is the IOP. Even if the IOP is normal, it is not that you cannot have glaucoma, and full comprehensive examination till the optic nerve should be done. And once you see if the nerves are normal, all the diagnostic tests which we do to corroborate our glaucoma is normal, then you can follow up the patient. But if the IOP is raised and still your optic nerves are fine, then basically look at the risk factors and then keep on close follow up of the patients. And you can do a diurnal IOP variation also, call for the office IOP. And I think that is all you have to swing between the normal IOPs, low IOPs, and high IOPs.
Right.
That's a very important message sent by Dr. Shashmita. So we will not rely much on the intraocular pressure. Rather than we should have a look on the disc. And if the disc is suspicious, whatever might be the intraocular pressure like, we should recheck it, because whenever we are checking the intraocular pressure, whatever might be the machines used, but tonometers used, but actually the suspicious disc should have repeated intraocular pressure examinations. If at all it is needed, then diurnal also, so to find out the cause for the damage.
Can I raise a valid point, Dr. Maitri?
Yeah. You want to add anything, Dr. Bibuti?
Yeah, a lot of patients we see in ROPD, those who have been put on medication with a single raised IOP record. So somehow this message needs to be sent that single raised IOP is not a single sole criteria to put the patient on medication. A lot of things are lost once we start the medication. So I'll just suggest that message to be sent.
Right. Another important point I'd like to highlight.
Patient presenting at 24, 25 millimeter fetch, and the patient is put on glaucoma medication. So that should be rather dissuaded, rather a complete evaluation need to be performed before we start with the medication. So that is
very important practical point. Another point also I would like to mention that whenever you are checking intraocular pressure, especially in a glaucoma clinic, the patient is very apprehensive, Whenever sitting in front of the slit lamp, they're so apprehensive that they just tighten their breath, that they hold it. And sometimes because of the neck structure also, sometimes we get high intraocular pressure, especially the necktie and all. This is very important practical point, because first of all, you just relax the patient, ask them that is not the number what you are getting. There are a lot of other factors also for your glaucoma examinations. So relax the patient, ask him what you are going to do, anesthetize the cornea properly. He should not squeeze, loosen the tie. These are all basic points, but you will get a perfect reading. And whenever you're taking one reading in one eye, do not write it, but because you take 2 or 3 readings and make average of it, and then you write that thing. So that is also another point, making the patient very comfortable in front of the slit lamp before taking the pressure. And another point is that sometimes patients do not use the medications when they're coming for follow-up. That has to be also mentioned in your file, that patient, when he has last used his medication, prescribed medication. That is also very important.
Dr.
Yes,
Maitri,
Dr. Bibuti? Yeah.
I just want to add something. What about Sears tonometer? What do you think? We always debate on that point, whether it has any relevance for the general ophthalmologist. If you don't have a gap, is it that even you can use for screening purpose in the rural areas a Sears tonometer? Because of late, it has been shown that even this year's tonometer can be useful in certain situations like post-keratoprosthesis glaucoma. In fact, that could be the only instrument that LDPI is working on that. Do you still recommend this? Because eye care, it has a recurring cost, the tip cost will be there, Tonopen also has a cost factor.
I think Dr. Sharma, because considering Indian scenario where the GAT is not available, definitely shorts should be at hand rather than relying much on the digital tonometer. So shorts, if it is done properly, it actually correlates well with the GAT. So it has to be done properly, and unless and until some special considerations are there, like high myopia and post PK and all these things, shorts correlates well with GAT. So in the situation where GAT is not available in Indian scenario, short should be there at hand.
It is at least better than doing nothing. At least better than doing nothing.
Dr. Manish is there? Hello, Dr. Manish?
Hello.
Yeah, Dr. Manish?
I'm there, madam.
Yeah, what is your take regarding shorts?
I think as much as possible it should be avoided. But in case you are in a place you don't have any other option, then maybe it can be used. But if you're treating glaucoma patient, then probably we should not be using SIORs to treat. We can max use it for screening. For example, NCT also you can use it for screening. But if you are you're actually treating a glaucoma patient, you should try to procure a Goldman appellation tonometer. And thankfully, a lot of Indian companies are there which are giving us Goldman appellation tonometer at a very reasonable cost now. So it can. Now,
Dr. Manish, actually, Dr. Prafulla asked the questions where it is not available. When the GAT is not available,
and we don't have anything,
then
it can be used for screening at max, but not for treating patients.
Correct. For treating, we should not.
One last question before we close this part of the session is: has any of the disinfection protocols changed in the post-COVID-19 era for anyone? Is anyone doing anything differently?
Dr. Bibuti?
I don't think we have changed the same protocol we are following, like installation and everything has to be performed.
Okay.
So the protocol is the same. Routine kind of practices.
Right. So I just raised this question because there's only one protocol we've changed, and we've done this after the NCT aerosol thing came out. So what we are doing is we are using a very dilute solution of povidone iodine. So we are taking 1 ml of the povidone iodine drops, mixing it with 9 ml of a lubricant, and we are instilling it before the NCT because we do NCT for all patients. So we instill that eye drop, do the NCT, and then we proceed as usual. So that is the only change that we have done. So I was just wondering whether anyone has changed any of the protocol.
Another practical question, as you have asked, Dr. Adiji. So before checking the intraocular pressure through applanation tonometer, you can put a drop of betadine in the eye.
Yes.
So it can take care of the viruses in the cul-de-sac. And that can also help you sterilize that tip of the applanation.
Does it not affect the staining?
It does not, sir. Yeah, that was an issue, sir. But usually we do the NCT at the preliminary stage. So we do the NCT first. NCT. So it takes quite some time, and by that time it usually goes away. Okay. And it's a diluted solution.
Diluting it, because if you dilute it, the efficacy may go down.
Yeah. Yes.
You can use in the normal strength also.
Yes, can be done in the normal.
Can I add one point, please?
Yes, sir.
Sure.
Please.
Yeah. So as Professor Sinha had said that even if one reading is high, obviously you should not basically start the treatment, especially if the nerve is healthy. It could be an ocular hypertension or one-off reading. But at least the patient has to be counseled regarding the same, because patient may not take it seriously and may not come for a follow-up. So you have to mention it to him that your pressure looks a bit high, but we need to recheck it. So he's reassured and he is aware of his problem.
Right.
That's what.
Yeah, that.
I'd like to move on to the next topic.
Yeah.
Can I?
Yeah, sure.
Dr. Ariji?
Yes, ma'am. Sure.
Yeah.
Sure, ma'am.
So I need the help from the back office or Dr. Arijit to introduce Dr. Sunil Jin. I'm not having the slides here. I'm so sorry about it. Yeah, Dr. Sunil Jin basically doesn't need any introduction. He is one of the senior national faculties So he's currently the director of IS Eye Clinic and Glaucoma Center, Worli, and heads the glaucoma services of the Eye Super Specialities, a group practice started in collaboration with LP Prasad Eye Institute in Mumbai. He finished his post-graduation at the LTM Medical College, Mumbai, and completed his fellowship in glaucoma from LP Prasad Institute in September 2001. He has publications in peer-reviewed national international journals to his credit. He has been a regular invited speaker at regional, state, and national glaucoma forums, and also performed live glaucoma demonstration surgeries at state glaucoma meets. He has contributed videos, talks, and chapters and various academic initiatives related to glaucoma, released by the All India Ophthalmological Society's AIOS Scientific Committee. He has been an invited faculty for the prestigious Glaucoma India Education Program being conducted by the Glaucoma Society of India to impart the education on glaucoma updates to general ophthalmologists all over the country. He also is a reviewer for Indian Journal of Ophthalmology. He was awarded by the Bombay Ophthalmologist Associations with the title of International Master for Professional and Academic Excellence in 2003. His areas of active scientific interest include angle-closure glaucoma, secondary glaucoma, different modalities in surgical management of glaucoma, including glaucoma implants. So we are right to choose him to give a view on gonioscopy. He's one of the most important favorite topic as angle-closure disease he loves to discuss it.
Okay, I'll just share my screen, please.
Yes.
Dr. Sunil Jin, please.
Yeah, is the screen seen?
Yeah.
Thank you, Moitri, for everything, the kind introduction. And thank you, Centaur, for having me on this forum. So let's start with the basic topic of gonioscopy and its clinical relevance in glaucoma diagnosis. Now, actually, if you look at this article way back in 98, Dr. Ravi Thomas and Dr. GC, they had found that the majority of ophthalmologists in the country do not perform gonioscopy routinely. And in my practice, I feel it's still the rule. Many of them do not do a gonioscopy, and all patients are being treated as in primary open-angle glaucoma. Okay. Now, when Dr. Ciota published her article, she found that almost 80% of the patients with angle closure glaucoma were asymptomatic. I believe in residency, we were always taught that angle closure glaucoma presents with an acute attack, But actually, this study proves it, that 80% are asymptomatic, and hence the importance of doing gonioscopy in every patient of glaucoma. Even in the APET study, when they found that all patients with angle closure glaucoma were analyzed, almost 42 patients were either unilaterally or bilaterally blind. And why was this? Because only one-third were previously diagnosed to have angle closure glaucoma, and only 8% had undergone an iridotomy. Again, proves my point that we are not doing gonioscopy regularly. We are not detecting primary angle closure glaucoma, and hence the patient is not being treated as an angle closure glaucoma, and hence the prevalence of blindness being more in these patients. So coming to gonioscopy, why should we master gonioscopy? Just like a routine examination, slit lamp examination, intraocular pressure measurement, fundus examination, gonioscopy has to be part of your routine eye examination once you detect a patient to have glaucoma. Now, gonioscopy actually allows us to directly view the site of impedance of aqueous outflow. Also allows you to visualize the different mechanisms which are responsible for glaucoma, like secondary glaucomas. And the final important point is it has to be repeated periodically to detect emergence of additional mechanisms. So it is not one-time gonioscopy you need to do. You have to repeat it every year because there could be additional mechanisms adding to your diagnosis of glaucoma. Now, we all are aware of why we can't look at the angle structures directly because of the total and internal reflection of the cornea. And hence, this is taken care by these mirrors of gonioscopes, and we can visualize the angle structures very well. Now, we have two types of gonioscopy, the direct gonioscopy and the indirect gonioscopy. The direct gonioscopy lenses are the Keeps lens, the Hoskin-Barkans, and the Swan-Jacob lens. The advantage is that it allows you a straight-on natural view of the angle. Okay, it allows you a simultaneous bilateral comparison of both eyes. The disadvantage is the patient has to be in a supine position, and hence it's mainly used for pediatric glaucoma surgeries And of late, with the newer angle surgeries like trabeculectomy, gonioscopy, and the MIGS, which are in vogue right now. So this is how you would visualize the angle structures using a direct gonioscope. And this is what trabeculectomy does. When you visualize the angle structures, it performs the ab interno trabeculectomy. This is how a MIGS implant is inserted. So once you know gonioscopy, you can kind of do these advanced surgeries for yourself. Now, coming to the indirect gonioscopy, the advantages, it offers the advantages of the slit lamp. That means you can magnify the image and you can see the angle structures more beautifully. There is controlled illumination, so you can visualize the angle structures based on low illumination or bright, and hence it's very convenient. It requires a coupling agents, the Goldman mirror, which is a single 2 and 3 mirror. There are the 4 mirror lenses, they do not require a coupling agents, but they have the added advantage of doing indentation gonioscopy, which I'll be demonstrating to you. So this is how you insert a lens. Once you put topical anesthesia, ask the patient to look down into the cup of the gonioscope and lift the upper lid and insert the upper part of the gonioscope along the upper limbus and then visualize the angle structures. Coming to the Goldman lens, which has been the time-tested lens, it has a very good advantage of it has a suction cup effect. So if actually once you insert the Goldman lens and if you leave your hand, it will not fall down because of the suction cup effect. And this keeps the lens centered and hence frees one attention for examination. So you are more at peace as compared to there are no corneal folds and all. And hence it is useful in laser procedures. The disadvantage is sometimes it distorts anatomical relationship of the angle, especially in the when you indent the peripheral sclera. The Gorio mirror it basically does not invert the image. So what you see basically, so if you're looking at this position, it's exactly showing the 6 o'clock position. And if you look at the nasal side, this is the 7 o'clock position and this is the temporal side. Whenever you rotate the mirror, this orientation remains the same. So you can exactly know whether you're seeing the more temporal side or more nasal side. Accordingly, you can visualize the angle structures very well without getting confused. With a 1 mirror or a 3 mirror lens, you can do what is known as a manipulative gonioscopy, wherein you tell the patient to look towards the mirror. As soon as the patient looks towards the mirror, you get a deeper view. So this angle, which looks kind of closed, okay, when you tell the patient to look into the mirror, you will be seeing a much deeper view and it's actually an open angle. But the problem is sometimes when you indent this peripheral sclera out here, this can cause artificially narrowing of this angle structures and the open angle might appear as a closed angle. Hence, the advantage of a 4 mirror lens, which allows you to do a dynamic gonioscopy. The disadvantage is it has a learning curve, and because excess pressure tends to cause corneal folds in the initial stages of your learning, and this can cause the visualization to be decreased. And these are the different lenses, the one with a handle and one without the handle, the Sussman's lens. Now, this is just to show you the difference between this is a 3 mirror, okay. The corneal end of the this is a larger one in a 3 mirror lens as compared to a 4 mirror. The corneal diameter is a very small diameter, and hence it indents the central cornea very well and allows us indentation gonioscopy. Now, how do you start about learning gonioscopy? This is what I did with my when I was a resident. You have to start with an experienced examiner or later in a group, and ultimately also look at the atlas. Because unless we know what normal is, we cannot detect the abnormal. So first perform in all normal patients who come to your OPD, so you know what a normal angle looks like. And these are the anatomic structures which I'll show you exactly. So this is when you put a gonioscope in an open angle, this is what you will actually see in an angle. It starts with the Schwalbe's line, which is the first structure from anterior to posterior. The Schwalbe's line is where exactly your descemet membrane ends. And it's like a shelf, a ridge which is formed. And that's why many times a lot of pigment gets deposited along this shelf. And that's why many times you misdiagnose that to be a trabecular meshwork. But when you go lower down, you will have the trabecular meshwork. Again, there are 2 parts to the trabecular meshwork. There's a non-pigmented trabecular meshwork and there's a pigmented trabecular meshwork. Then there is a scleral spur and then there is a ciliary body band. So it's alternate brown and white structure, what you see in these angles. Now, once you've inserted the gonioscopy, you are supposed to put some questions in your mind. First, is the angle occludable or not? That means you are trying to diagnose or differentiate between whether it's an open angle or a closed angle. Second question will be, are there any additional abnormalities in the angle? So are there any additional neovascularization, any pseudoexfoliation? And third, you also look at the curvature and the insertion of the peripheral iris to know whether there is element of juvenile or infantile glaucoma in these patients. So there are certain testing conditions which you have to keep in mind, which are very important, which will allow you to diagnose angle closure very properly. So first, when you want to question whether it's angle occludable or not, you dim the room lights. Okay, the patient has to look straight ahead and decrease the illumination and the height of the slit beam so that the slit beam does not cross the pupil, because if it crosses the pupil, there will be artificial constriction, and artificial constriction will cause a closed angle to open up. So this is a very important testing condition which you have to follow. Then as soon as you look into the angle structures, you will realize the beam which goes across the cornea. There's an epithelial beam and an endothelial beam which come to focus on the first structure, which is known as the Schwalbe's line. This is known as the corneal wedge test. This is where you start classifying the angle or grading the angle. So once you look at this thing, then you look below this. So if you can see all the structures below this, that means it's a wide open angle. If you cannot see this or even less than that, it's an angle closure. I will show you in gonio photographs as and when I come to it. There are different grading systems. I usually follow what is known as the RP center system, where whatever structure you see, you note down in your drawing. So if I see the trabecular meshwork, write as trabecular meshwork. If I don't see, I'll make it as a 0. And this is the additional indentation gonioscopy, which I will show you with a 4 mirror. Basically, because the corneal diameter is the smaller of the lens, it indents the central cornea very well. As soon as it indents, the aqueous in the center gets pushed to the periphery and the entire lens diaphragm goes backwards. So this is how you can detect whether the patient has angle closure or a open angle. And in angle closure, whether there is a positional closure or a cynical angle closure. Okay. Now, once you have detected diagnosed whether open or closed, then you increase the room illumination, increase the height of the slit beam and allow the pupil to constrict, so that you can see additional structures in the angle. Then also you look at the curvature. This is how a regular curvature of the peripheral iris should be. But if you see kind of a peripheral convexity, this is usually seen in pupillary glaucoma. If there's a concavity, usually seen in aphakic glaucoma, pigmentary glaucomas, this is how the structure of peripheral iris appears. And the insertion of the iris also is equally important, especially in juvenile open angle glaucomas, where it's quite anteriorly inserted. Now, this is a very common question which we get as glaucoma specialists: which gonio lens should I buy? So there is a very scientific explanation which has a preference. So let's take a kind of this diagram. This is a wide open plane, and you can see the man, tree, and the house. And there are two people. There's an observer A and the observer B. Now, irrespective of whatever position or your height of the observer, they both can see all the structures. So this is what exactly happens in the open angle. So in an open angle, you can use any mirror, whether it's a 4 mirror or a 1 mirror or 2 mirror, because there's now no obstruction which is coming. The problem comes in this, basically, where you have a hill which comes in front of you. So obviously the observer A, because he has a lower height, he can just see the top of the house. He can't see the tree and the man standing. But as soon as you increase the height of the mirror from A to B, so here with B can observe not only the house, but also the tree. Okay. So the first criteria, as soon as you increase the size of the length of the mirror, you get a deeper view. And then if you change the position from A to A dash and B to B dash, you will see further inside the angle. Okay. So the more closer you are to the center of the cornea, you will be able to see more of these deeper structures. So this is the logic behind the mirrors. So the factors affecting the visualization, especially in a narrow angle, which is very common in our country, is the height of the mirror, the central position of the mirror, and also the effect of curvature, which allows you to do indentation gonioscopy. So when you compare these basically things, so first is, as I told you, the mirror height. So if you look at the mirror height, the single mirror and the 4 mirror have the same height. Okay, the 3 mirror has a lesser height. Then you look at the mirror from the center. Okay, so the single mirror is again closer as compared to 4 mirror. But the most important thing is this: the corneal diameter is a smaller, and this allows you to the indentation gonioscopy, which is not possible with a single mirror and a 3 mirror. So you can have a single mirror lens, which is better than a 3 mirror. But as a glaucoma specialist, we prefer the 4 mirror of this extra feature which it provides. So now coming to how gonioscopy helps us, it not only helps us diagnostically, but also therapeutically to do certain laser procedures and goniotomy and mixed surgery. Now let's go through certain gonio photographs quickly. This is what I've shown you. A wide open angle would appear like this. So when you see something like this, you will feel that this is a trabecular meshwork. Actually, no. As soon as you do indentation, the entire lens diaphragm moves forward. And this is actually angle closure. So that was not the trabecular meshwork. The trabecular meshwork is hidden behind. Plus, you can make out this as certain cynical angle closure also. It is not appositional closure. So this is the advantage of indentation gonioscopy. Here on indentation, the complete angle is zippered up. So there's complete peripheral anticyanic and it cannot open up. This is how a plateau iris would appear to you. So as soon as you do indentation, the peripheral, the ciliary processes are anteriorly positioned, and that's why you get a peripheral convexity. Then this is where the equator of the lens is there, and then again the convexity of the lens comes. So this is what is known as a sine wave sign, which is classical of a plateau iris. This is how anterior insertion of peripheral iris in juvenile open angle glaucoma. This is how a posterior embryotoxin, a prominent Schwalbe's line, basically appears as. Coming to secondary angle closures, okay, you have to differentiate between a iris processes and a synechiae. A synechiae will always cause a pulling up of the peripheral iris, and it will go directly and get attached to the this almost Schwalbe's line many times. Here, the iris processes go along the concavity of the angle. They do not go directly pull up the iris. Coming to neovascular glaucoma, which always starts with small tufts of blood vessels at the pupil, and then they spread over the iris surface, ultimately go and arborize over the trabecular meshwork, causing complete cynical angle closure. And this is how these blood vessels appear going across the scleral spur. These are not all abnormal blood vessels, basically. This is how in the olden days when ICC were done, and this is how fibrovascular ingrowth would occur. Intraocular tumor can present, and you can detect it on gonioscopy if you have a localized anterior synechiae forming, peripheral anterior synechiae forming. And basically, this is how a malignant melanoma of ciliary body appears. Coming to, this is pigmentary glaucoma. This is all Sampolesis line. You have dense pigmented trabecular meshwork. Exfoliation syndrome. You will see these flakes in the angle structures. This is when the vitreous loss occurs. You will realize why the vitreous is causing all these inflammation of causing trabeculitis and secondary glaucoma. These are older generation lenses which used to cause extensive fibrosis and synechial closure. This is an interesting case post-phaco. A beautiful phaco was done by my colleague, but pressures would keep on spiking, intermittent uveitis. Patient was referred to me after a month or so. We put in a gonioscope and we realized there was a nucleus piece which was still roaming around, going behind the pupil and coming in front. So one day we could detect it and we realized what was the cause of the intermittent uveitis causing secondary glaucoma. So the importance of gonioscopy even post-phaco. Post-traumatic, this patient came to us with a unilateral glaucoma. When you see this pupillary rough is well maintained, but here you see there are sphincter tears. So when you ask the history, the patient recollects that he had an injury somewhere in childhood, and that was the cause of unilateral glaucoma. And this is basically angle recession. This is a refractile foreign body seen in the angle. This is basically post-uveitis, where you'll see inflammatory goniosynechiae. This is different from angle closure goniosynechiae. In angle closure goniosynechiae, you won't see the angle to be wide open. So when you see a wide open angle with the synechiae, it's usually an inflammatory goniosynechiae. This is silicone oil in the angle. Now, post-trabeculectomy, also gonioscopy helps you. This is to show you patient operated for trabeculectomy. Day 1, the pupil was seen to be slightly peaked. So when you insert the gonioscopy, you realize the peripheral iridectomy was not adequate and the peripheral iris went and obstructed the internal ostium, causing a rise in pressure. So all you have to do is either iridotomy with using a YAG laser or start pilocarpine, constrict it, let the peripheral iris move away, and the trap starts functioning again. This is when a positive pressure during iridectomy, the vitreous came and obstructed your internal ostium, basically. Certain therapeutic applications, SLT, we know we can use the gonioscope, and sometimes traumatic aniridia, you can do a direct cyclophotocoagulation because the ciliary processes are visualized. Non-glaucoma conditions, this is a patient who presented to us with a swelling in the eye. When you see this bleb was there was no history of glaucoma, no history of glaucoma surgery also. And basically a small incision glaucoma surgery was done in this patient. And when you do a gonioscopy, you see there is a fish mouthing of the wound. So all you have to do is open the conjunctiva, take a suture, and that's all. And the bleb disappears. This is a pseudo-bleb formation which had occurred. So just to conclude, gonioscopy is mandatory for the diagnosis and management of glaucoma, evaluation of the internal ostium in the post-trabeculectomy period, and also in certain non-glaucomatous conditions like ciliary masses and inadvertent blebs. Thank you.
Thank you so much, Dr. Sunil. It is really good for the beginners. So there's a question from the audience. First of all, I like to just ask you. This is from Dr. Nagendra Prasad. He has asked you: does the length of gonioscopic mirror is important for grading the angle?
For grading?
Yeah.
No, it's not. As I explained to you, the length of the mirror is not for the grading. It allows you to look deeper into the angle structures. That's what. So grading is once you visualize the image, then you can do the grading, basically. The problem occurs in some of these narrow angles, you can't see beyond the hill. So this longer mirror will allow you to see a bit beyond the hill. That is the advantage.
So one thing is very clear from his discussion that from the beginning, if we start practicing with the 4 mirror, it will be very advantageous for everybody, right, Dr. Sunil?
That's right. Because during our residency, there was no 4 mirror available.
Yeah, so it is we are lucky to have it for the beginners. They can start it with that, so that they can start from the beginning with a very advantageous position, can have this indentation gonioscopy done for that. And practice is the
students. For the students, I would like to add, the Indian lenses are also quite very cheaply available. So it's the department can purchase it easily. And allow the residents to start doing gonioscopy with a 4 mirror.
So I have a question to you that gonioscopy is it is a must for all glaucoma practitioners for the glaucoma practice, but for the comprehensive ophthalmologists and for general ophthalmologists, especially in the busy clinic, what is your take? Whether they're going to do it in everyday practice on every patient, or what is your take like?
No, so I also do general ophthalmology practice. So it's only when I suspect a patient to have glaucoma, a normal patient walking in, to have very shallow chambers, okay, or the pressures are high or borderline, then basically I will just do the gonioscopy. At least I'm aware of what the angle looks like, And if the pressures are borderline, then there are sometimes, as I told you, there's mostly asymptomatic angle closure glaucomas. So if you don't detect them, they might go into acute attack of glaucoma, or they might have chronic changes over a period of time. So always keep the gonioscopy handy. That's what. It is not for every patient.
Especially for the Van Eyck gradings. If you get the grading, so in those cases, you must do these things.
Very much. And if you see if the chamber is shallow in the periphery, just stick in a gonioscopy. And the advantage of the 4 mirror is it doesn't require the jelly and all. So
yes, it is immediately
just put paraffin and you can just visualize it immediately.
So as the definition of angle closure disease is as actually based on the gonioscopic findings. So unless and until we do the gonioscopy, we will be missing the angle closure disease. And as you know that angle closure disease, if we can pick them early, we can prevent the glaucoma just by doing a timely laser. So it is a very important thing for the gonioscopic. And the key message is that keep doing it with the 4 mirror for all the patients, especially for the myopes, especially for the high myope. Usually they have the open angles so that you'll be getting all the structures, and corneal wedge technique is the clue for the beginners. So for the time crisis, may I request Dr. Arijit to invite our next speaker, please.
Yes, ma'am. It gives me great pleasure to introduce Dr. Professor Bibuti Prashan Sinha. He did his MBBS from the Government Medical College, Jabalpur, and MS post-graduation from SSMC and GMH Rewa in 2002. He completed his senior residency at RIO IGI MS in 2002. Starting from his senior residency, he is serving in the very same institute till date. He graduated among the ranks to become the head of the department in the year 2014. He is one of the youngest head of the departments in ophthalmology. He has been recognized by Times of India as the Times Ophthalmologist of Bihar in 2014. He has also received the Young Achiever Award of ISC KRS 2017 and the IRRSI Gold Medal in 2016. He has also been awarded Dr. A.K. Prasad Gold Medal and Dr. Ajit Sinha Gold Medal by Bihar Ophthalmological Society in 2012. He has served as editor, CSC of Bihar Ophthalmological Society, currently honorary secretary of the society. He is also serving AIOS in his various capacities. He is the principal investigator of various multicentric trials like Topaz, and currently he is working on the BIRAC DBT trial. So that is a very impressive CV, and I would like to ask Dr. Sinha to start his talk. His talk is on optic disc in glaucoma, which is a very, very crucial part of the examination in the diagnosis of glaucoma. So over to you, sir.
Thank you, Arijit, for your nice and considerate kind of introduction. I'll be talking on assessment of optic disc. Let me. Yeah. Is my slide visible?
Yes, sir. Yes, it's absolutely visible.
So I'll be talking on the assessment of the optic disc. Since we are already running late, I'll skip few of the slides for saving a little bit of time. So optic nerve head is the distal portion of the optic nerve extending from the retinal surface to myelinated portion. And an important thing is that 1857, Von Graffies was the person who correlated optic nerve head with the glaucoma. Going into the little details of the basics of disc, it's a part of optic nerve head which is visible with ophthalmoscope. And there are intrapapillary part, optic cup, and the neuroretinal rim, and which is separated by the scleral ring of Erskine, which will give you actually the end point of the disc. So coming to the disc shape, usually oval, the vertical diameter is little larger, we have to remember. And cup is little wider in the horizontal zone, horizontal meridian. Coming to the disc, normal disc ranges from 0.86 millimeter to 5.54 millimeter. It can be a little larger also in cases of myopia. The cup is the central part. It varies in forms and size, but we need to remember that the symmetry of neuroretinal rim around the cup is usually proper. So we have to properly visualize the cup as well as the neuroretinal rim. The neuroretinal rim is actually the most important from the point of a glaucoma person. It is a tissue outside the cup and contain the 1 minute. So this is the neuroretinal rim, which is very, very important from point of view of the glaucoma surgeons, and it contains the retinal nerve axons. And we have to remember that ISNT rule has to be followed. That means the inferior neuroretinal rim is the thickest one, and the temporal one is the thinnest one. We have to also remember the RNFL and the tectonic placement of these nerve fibers in the optic disc to actually correlate with the visual field changes when it occurs in the patient. Now, when we diagnose and when we do the evaluation of optic disc, there are 4 simple goals. One is diagnostic, that we have to distinguish between the healthy and the sick disc, whether this disc is actually suspicious or whether this disc is completely healthy. Once we diagnose this disc as a sick one, we have to quantify whether the damage is mild, moderate, or advanced disease is there. And then during the serial evaluation, we have to monitor the changes, whether it is progressing or not progressing. And we have to also identify the rate of changes, which can be performed better with a newer armamentarium which we have. So if we have a disc like this, where there is an inferior notch, then the things are very easy for the person of glaucoma or even for the general ophthalmologist. But what about this? A 27-year-old female with eye strain, family history positive, IOP upper borderline, and CCT is 544 and 540 in the right and the left eye. This is the disc, approximately 0.5 CD ratio. If we consider CD ratio, again, this is 0.4 to 0.5. Visual field is approximately right in the right eye, but in the left eye, there are a few depressed points. What to do? Now, these are the discs which requires actually a proper evaluation. So coming to the glaucoma suspect, there are usually there are two type of suspect in clinical practices. I'll not go by details of the book, but usually you suspect either with the disc or with the IOP. So if the disc is suspicious, we usually go with the evaluation of disc and then do the functional evaluation. If the IOP is high, the first evaluation is usually the corneal thickness to identify whether our IOP is correctly measured or not, and then we proceed for further evaluation. If both are under suspicion, then the life is little easier. But only if disc is suspicious, then you need to very minutely evaluate this disc to find out what is wrong with the disc. So how that can be performed? Slit lamp biomicroscopy, it will give you a stereoscopic view. Direct ophthalmoscopy will give a good magnification, good in good hands. And a lot of people in the periphery are doing that. Indirect ophthalmoscopy will also give you information. And then the optic disc photography is the most important thing for documentation as well as monitoring the progression. So optic disc evaluation, what we look for? In the qualitative, the shape and the width of NRR. For the then we have to do the evaluation of RNFL and we have to look for the optic disc hemorrhage. And in the quantitative, we have to see the optic disc size, the rim width, and the RNFL thickness. So there are 5 basic rules, and these few slides are very important, and I consider them like one of the best slides presented to all the ophthalmologists. So rule 1 is observe the scleral ring, identify the disc margin, and identify the limit, so as you are able to actually identify what is the size of the disc. Do it in 2 meridian, but not if you can't do, at least do in 1 meridian to identify whether the disc is a small, medium, or a large size. You can also use a small apertures of well challenge, which throws approximately 5 degree of well challenge, the smallest reticule. It is going to give you a 1.5 millimeter light source on the disc. So you can identify a small disc with that. Or the best way is to do a slit lamp biomicroscopy with help of either 70D, 68D, 78D, or 90D. But remember, we have to use the correction factor. If you are using, in my personal practice, I use 78D. So it gives approximately 1.1 is the correction factor, but approximately it gives a proper view of the disc and also the size of the disc. Now, size of the cup varies with the size of the disc. Large disc have large cup in healthy eyes. So it's large disc, the small disc with a small cup can be sometimes suspicious, but a large disc with a large cup can have a larger volume of NRR, and that can be even normal in the normal patient. So 1.4 is small, 1.9 is average, and 2.4 is larger. So we have to identify actually the small, medium, or large optic disc. That is the first rule. Then once the disc size has been evaluated, I'll go skip this slide. Once the disc size is evaluated, move to the neural retinal rim. Now, this is the area beyond the optic disc, this pallor. From there to the worsening area, and so margin has to be evaluated to identify this neural retinal rim. And this is the most important part of evaluation. You have to actually see the NRR in different quadrant: inferior, superior, temporal, and nasal. You can have a sloped margin on the temporal side. Don't get confused with that. You have to actually look at the superior and inferior pole, because these are the 2 poles which are going to be affected first. So try to find out any alteration in the ICNT rules. So coming to the example, this is a large disc, but the NRR is apparently little healthy kind of a disc. So ICNT is also preserved, but in this case, you can see that the inferior NRR is little thin, and so this patient requires little further evaluation. You have to also look for the localized rim thinning, so localized notch or a generalized loss of NRR associated with the parapapillary atrophies. Then observe the disc and pallor. So if the disc pallor is more than the cupping, it usually goes in favor of a non-glaucomatous optic neuropathy. So if the pallor becomes more, it usually occurs in the primary kind of the optic atrophy. And this usually goes in favor of non-glaucomatous optic neuropathy, and that has to be actually clearly evaluated. And the rule 3, we have to actually evaluate the retinal nerve fiber layer, best performed with the red-free light, looked at the striations, brightness and visibility of parapapillary retinal vessels, look for the diffuse and localized retinal nerve losses. So normally slit-like, groove-like spindle defects are seen, but focal wedge or slit defect with the apex toward the disc are seen. These are actually important from point of the glaucoma. So these are the brightest striations, and there is a diffuse loss. The disc, the loss, the apex is towards the disc and towards the area where NRR is actually thin. So you have to clearly look for those changes in the diffuse, in the RNFL when you're doing a proper evaluation of the RNFL. Coming to the parapapillary atrophy, zone beta is very important. Zone alpha is not that important, and you need to remember that zone beta has not to be confounded with the normal crescent which are present. And you have to also remember that this is atrophy of the retinal pigment epithelium, and the choriocapillaries is the zone beta. And important thing is the width of the zone beta is inversely correlate with the rim width at the same area. So if suppose there is a NRR loss in this area, this will correlate with the appearance and the enlargement of the zone beta in this zone. So that has to be seen. Then go to the optic disc hemorrhages. Again, use a red-free light to find out whether there is a splinter hemorrhage present. They are usually present in the peripapillary zone, covering the disc and the margin of the peripapillary area. And so they usually are indicative of appearance or the progression of the disease. So normally they disappears after 2 to 6 months, and then that is the time when the RNFL loss actually appears in these kind of the disc, and they are usually present in the inferior zone and the more so in cases of normotensive glaucoma or low tension glaucoma, and they are signs of progressions. So detection of disc hemorrhage requires careful optic disc evaluation, and then you have to very minutely see those optic disc hemorrhages. So red-free photography is very important tool when you evaluate a disc to actually see the blood vessels over the disc, to actually see the hemorrhages here and there, and then also to evaluate the RNFL in these patients. Then stereoscopic optic disc photography is another good armamentarium. Now everyone is having a good kind of slit lamp photography system in most of the clinics are having. So try to have photograph of these discs for further evaluation and further to check about the further progression of the disease. Then we have different armamentarium like OCT, HRT, and GDX, which are going to be dealt by Dr. Manish and others. So I'll not go into the details. One word about the CD ratio versus DDLS. Now the CD ratio was in 1967, but remember the CD ratio does not consider the optic disc size when it works there. So it can miss a lot of information. A standardized way of documenting, but it can diagnose the progression, and the diagnosis can also be given by that. But it misses the small changes occurring in small areas of neuroretinal limb. So the DDLS scale came, and it incorporates the effect of the disc size and the focal rim width into the clinical grading system. This is highly reproducible and does correlate strongly with the degree of field loss. The system categorizes the disc as a small, medium, and large, and then depending upon the loss of NRR in different area, it gives you have to actually measure the width of the thinnest part of the rim. So this is the highest kind of loss which we can evaluate. There is more than 270 degree of loss of NRR with actually there is no NRR in this zone. So this is going to give you information about the DDLS stage. Even if you're not using this DDLS scale, what does that mean to us? That means that the two things most important from our point of view or the clinical perspective point of view is you have to remember that disc sizing has to be performed. And number two is you have to give a lot of importance to the NRR rather than the cup disc ratio. So few case scenarios, this is the case. Number one, again, the first case which I presented, 27-year-old female with eye strain and family history of glaucoma. IOP of 21 to 24 and CCT approximately, which is normal average. You can see the disc, approximately 0.5 CD ratio, NRR appears to be approximately normal in all zone. Here again, appears to be normal, but look at this point. The NRR is little bit thinner as the other surrounding areas. So when we did the visual field estimation, you can see the visual field changes are present, and some of them are actually correlating with the optic nerve changes on the OCT also. So when we go to the final slide, what we see is there are changes which are correlating with the visual field changes and again to the OCT changes. So this is how the structural functional correlation has to be performed to finally achieve the diagnosis in the patients. So it is very important from clinician point of view to give a proper assessment of the disc to reach a diagnosis of glaucoma. Thank you very much for your patience. Thank you, ma'am.
Thank you so much, sir. That was an excellent presentation. So I'll just ask one small question. When it comes to you documenting your discs, do you prefer your hand-drawn diagrams on your case sheets, or do you prefer taking a photograph and keeping it and for further documentation?
Still, we try to teach our students to create handheld diagram on the slit lamp biomicroscopy when they are performing. And then later on, these patients are basically taken up for documentation purposes with a stereoscopic photography. And that's a very good way of dealing with once you're doing making a diagram of the disc on slit lamp. Actually, you are very minutely finding out the changes which you may have missed otherwise.
Right. Any other questions, Maitri ma'am?
Now, unmute yourself.
Okay, in the meantime, I'll just ask another question. That disc examination is probably one of the most important examinations, but with the advent of all these other tools, the OCTs and HRTs, like you've mentioned, has disc evaluation taken a backseat?
I don't think it should actually. But yes, in clinical practices, we are seeing that the disc findings, usually the clinicians are mentioning only the CD ratio and that the patient is taken out for the OCT, which actually is not the greatest tool to actually work with. In my clinical practice, I usually don't use OCT for disc evaluation or the disc sizing. Disc sizing is one important thing that I can do with the OCT. But other findings, I don't rely upon. The clinical findings are more important for me as compared to the OCT finding. Rather than I'll work with the RNFL data on the OCT for my clinical diagnosis. That is more important.
Right.
Just to sum up all these things, one thing is that what is very clear from his discussion, we should not leave any patients without looking at the disc, whatever might be the complaint they are coming with, whether it is dilated or undilated, and preferably red-free. Red-free, just have a look on the disc. You can get a lot of information if you are doing it in front of a slit lamp biomicroscopy. So if you are suspicious about that disc, then dilate the patients and look at the fundus, other things, whether it is correlating well with your disc findings, but do not leave the patients without looking at the disc. Is that clear message, Dr. Bibuti?
Yes, ma'am. Absolutely.
Yeah. So anyone wants to add anything out of all our speakers? Dr. Sunil?
So that basically disc examination also is one of the pillars of glaucoma diagnosis, and Professor Sinha very aptly showed with those photographs that every disc is different and you have to visualize it. And main thing, you have to draw it down. I still draw all my diagrams. I don't rely too much on fundus photography because that helps me in analyzing, every time the patient comes, are there any new changes or it's maintained apart from doing the perimetry. So I think everything has to be documented on paper, and that's what, because these are all long-term follow-ups which you need with these patients.
So this drawing is still having a role? So
yes,
even if you don't have this fundus photography camera also, so keep drawing those things and follow them up nicely. You can level them there also. So with that, we like to invite Dr. Manish Singh for our next discussion. So Dr. Manish Singh also doesn't need any introduction. He is now the Executive Director, Netraland, the Super Speciality Eye Hospital, Kolkata. Also, he is a Senior Glaucoma Consultant at BBI Foundation, VIP Road, Kolkata. He is at present the Joint Treasurer, Glaucoma Society of India. He has done long-term glaucoma fellowship and is former consultant in Shankar Netralaya, Chennai. He was the East Zone representative of Glaucoma Society of India 2012 to 2014 and was the Glaucoma India Education Program Coordinator 2016 to 2018. He has more than 170 presentations, published 17 articles in peer-reviewed journals, and 3 chapters in ophthalmology books. He is a very good speaker and a very dynamic fellow. Dr. Manish, please carry on with your discussion.
Thank you so much, madam, for such a generous introduction. Am I audible, madam?
Yes, you are, Manish.
You are very much audible.
So next around 12 minutes, I'll be discussing about the importance of perimetry in glaucoma diagnosis and progression, and I'll try not to make you miserable like that person. So perimetry, as we all know, is very, very important in glaucoma point of view. Basically, what we are doing in perimetry is we try to measure the visual function at specified defined points in the visual field. And it has always remained the gold standard for glaucoma point of view for both diagnosis and for seeing progression. So many newer machines have come, HRT, OCT, GDX, but when it comes to the definition of glaucoma, it is still about the visual field changes, so perimetry is still the gold standard. We won't be going into the interpretation of visual field because we all know about these 8 zones, and this is not the topic of today's discussion. But it is important to know that whenever you are interpreting a visual field, go zone by zone, see in detail, because every zone has its importance and we should be aware of that. So classically, there are 8 zones, but we know that the newer machines have the 9th zone, that is the visual field index. I'll be touching about it in the later part of my presentation. Important point also is that what is the test strategy you're using for your patient? Use the correct glass for your patient, and pupil diameter should be more than 2.5, because if it's a very small pupil, you'll have a falsely depressed field and you have a falsely diagnosis of glaucoma. The various strategies available, but the most popular one is the CETA standard. Among the various programs we currently use a 24-2 routinely for all our glaucoma patients and 30-2 for the neurological diseases. But you also use 30-2 for your glaucoma patient. 10-2 and the macular program are reserved for certain special cases. We'll come to it. The various types of glaucoma field defects that can be seen. So I'm showing here the different grades of glaucoma field defect, from the nasal step to established superior arcuate defect, and then tunnel vision and a total loss. So the different stages of glaucoma defect. APGS is very nicely classified that what are the characteristics which tells you that it's a glaucomatous field defect. One, that the field defect will follow the pattern of RNFL. It will rarely cross the horizontal midline, and generally it will be located between the 5 to 25 degree of the fixation. It will be reproducible and should not be correlating with any other disease pathology. So very important, you have to dilate the eye. Obviously, if it's a close angle, you have to do a PI and then dilate, and see the fundus also, and try to correlate that there is no other disease like a BR view or a drusen or a tilted disc or laser scar which is causing the field defect. So these things has to be excluded. We should also be aware of non-glaucomatous field defect, because, for example, large blind spot in a papilledema or a homonymous or a hemianopia, because a lot of these glaucoma patients, when you do a perimetry, you can have these type of centroscleral scotomas, which you need to understand these are not classical field defects seen in glaucoma patient, and you should investigate to look for other possible causes. Again, we are all aware of the Anderson-Patella criteria. Classically, Anderson-Patella criteria, as we all know, is cluster of 3 non-H points in a 30-2 program, each of which has a sensitivity less than P, probability less than 5%, and one of which has a probability less than 1%, with a PSD less than 5% and GST outside normal limit. So you should have at least 2 of these criteria. This is the Anderson criteria, which is, so basically Anderson criteria tells you that this field has a probability or a chance of being glaucomatous. But I'd like to share some cases to understand the diagnosis and role of diagnosis of perimetry in glaucoma. So this is a patient who is a glaucoma suspect. It comes to your OPD for opinion. The pressures are normal. Angles are open on gonioscopy. The CCT is slightly on the higher side. You can see the disc in right eye and the left eye. You've done a field. It shows superior and nasal defect. Again, in left eye also there is superior and inferior defect. But very important point which Dr. Bibuti sir was also highlighting, that the disc and the field has to be clinically correlated. When you see the disc in right eye and if you see the field defect, there are no obvious thinning of rim in this patient. There is no RNFL defect. So there is no reason why this patient should have this nasal or superior defect. It is not matching with the disc finding. Similarly, in the left eye, definitely the cup is larger, but what is important is to look into the rim, look into the RNFL. When you correlate with the field, you see there are superior and inferior field defect, but there is no such inferior or superior thinning of the NRR, which should corroborate with this. So whenever you have this type of discrepancy, you should always try to repeat the field test. And you see in this case, when you repeated the fields were normal. So this patient was basically in the learning curve. A classical correlation is when you have a patient with inferior notch like this and a classical superior defect. So whenever you see a field, always dilate the patient, always see the disc and try to correlate. Just a visual field report per se actually has got no value. This is another case of inferior thinning with a disc hemorrhage and a superior field defect. So very important certain guideline we should follow in every patient. One, patients will have a learning phase in perimetry. In fact, almost 50% patients do have a learning phase, which is more common in first and second visual field. Always clinically correlate. And in case you have a doubt, you're not very sure, don't jump into diagnosis. Unless the pressure is high, you need to treat those patients. But if the pressures are normal, angles are open, you're not very sure, looks like a borderline case, you can always reevaluate the patient after a month or 2 weeks. Nothing is going to happen in a week or two. Don't jump into the diagnosis of glaucoma. The recent EGS guideline also has highlighted that visual field is extremely important for both diagnosis and for progression in glaucoma. And they have mentioned that this is the more important than even OCT for seeing the progression. You should do 3 perimetries in a year for first 2 years to establish a proper baseline. And they have mentioned that you at least need a 2 year of follow-up to see the rate of progression, which is very important to classify your patient, whether they are fast progressors or slow progressors. In case the rate of progression is more than 2 decibel per year, they are classified as fast progressor, and these patients you need to aggressively manage. I'll share another case. This is a patient, a 52-year-old gentleman who came for a glaucoma opinion. He has a very strong family history of glaucoma. His father was having glaucoma. His brother was having glaucoma. Pachymetry was 540. The pressures were normal. Angles were open. The disc had mild inferior slope, nothing significant. We did a baseline fields. The field were normal, and we just asked the patient to be under follow-up. But over time, we saw that the pressure were maintained, but there were some field defects which were not very significant. But in 2018, we saw that the field defects have increased, the pressure has also increased. But again, this is not a classical field defect, what we see in glaucoma patient. As I was mentioning to you, the field defect should cross the vertical meridian. In this case, it is localized to one segment. But if you see the disc, definitely there is some inferior thinning in the left eye and the right eye. There is some inferior slope. So sometimes there can be a mixed picture. You can have a disc which is looking like glaucoma with a borderline pressure, strong family history. But if you see the field, there is a progression of field over a period of 4 years, but the field progression is not matching with glaucoma. So in cases like these, you should always consider neuroimaging. And in this case, what we found, the patient actually had a pituitary tumor. So whenever you have this atypical progression, even in a patient with glaucoma or a glaucoma suspect, when you have atypical progression, when you see the pallor is more than cupping, or the field defect is obeying the vertical meridian, or there is a unexplained rapid progression, always do a neuroimaging. We should not try to become a Robin Hood and try to save money for the patient. Whenever you have doubt, do consider neuroimaging, because a lot of time you will see you will be making a life-changing diagnosis for your patient. And we have detected so many tumors in our glaucoma clinic because these have been missed on a routine evaluation. Again, perimetry is also a role in staging. There are various staging algorithms available, but the most simple one is that you can, in early glaucoma, you have mean deviation less than 6, moderate glaucoma 6 to 12, and advanced glaucoma, you have mean deviation more than 12. So you can see, you can classify your patient based on a visual field to mild, moderate, and advanced, which is useful to discuss with the patient. I'll quickly run through certain examples, which is important whenever you are assessing perimetry. For example, this patient, you can see there is superior field defect because of ptosis. When the patient lids were taped, the field had become improved. This was a patient where a patient was using a high plus power, and because of that, they were rim defect. These patients, you can repeat the perimetry using a contact lens, and you will see improvement of perimetry. So whenever the lens power is more than 6, you can consider using a contact lens. Pupil diameter, if it's small, you can see there is a depression of the field. Whenever it is less than 2.5, we dilated the patient and repeated the fields improved. Again, a wrong glass was placed in this patient. Instead of a myopia, by mistake, the perimetrist has placed a +1. So you can see a total depression of field. When you put the right glasses, you can see the perimetry has improved. You all are aware about the false positive seen resulting in this white scotomas, and then you have the cloverleaf pattern because of high false negative. Again, a lot of time we are doing perimetry using masks nowadays. So because of masks, you can have fogging, and loosely fitted mask can lead to inferior field defects, and there have been reports of that. So in case the patient is using mask, properly tape the mask so that you don't have false field defect because of the mask. Role of perimetries is extremely important. Explain the patient in detail about the procedure. Tell the patient that even a normal person will miss 50% of light. So patient should not panic, and patient should perform the test properly. I won't be going into detail of VFI, but VFI is basically gives you the percentage of the normal field after adjustment for age. So suppose the VFI is 80, it means that this visual field is 80% of normal. VFI has role in assessing the progression over time. Here the central points are given more important compared to mean deviation, and it is less affected by cataract compared to mean deviation. So you can see a patient with VFI of 94. Over time, if it's coming down, you can see that the patient is progressing. As I was telling you, that clinical correlation is extremely important. For example, this particular patient, sometimes the patient will just send you a perimetry report on WhatsApp. You can see this is a classical glaucoma field defect. There is superior defect. It is crossing the vertical meridian. It is following the Anderson criteria. But when you dilate and evaluate, you see basically the patient has got a coloboma. I'll quickly run through the progression. There are various ways to detect progression, and there are definitions available of what is this new scotoma or deepening and enlargement of scotoma. But the most commonly used is the overview printout and the glaucoma progression analysis. Overview printout, we all know they have multiple fields. It will not provide you any statistical software, but you can see over time how the defects are increasing and can give you an idea about the progression. But GPA is something which is very good, and it provides you a proper statistical backup. In this case, 2 fields are used as baseline, and based on that, you can compare the future field, and it will give you an idea whether the patient is having a possible or a likely progression. So in very simple word, it can give you an idea which patients are progressing and which are not. I'm not going into detail of this. And it also provides you the VFI plot, which I use very commonly in my patient. So if you see that the patient is progressing fast and the VFI is not stable, this gives you an idea that your treatment is not adequate and you need to step up your treatment. Before I conclude, I'd just like to mention a little bit about the HVF 24-2C faster program, which is now available in the machines. It's a newer version of the CETA, which is the CETA faster. The advantage here is that it is 50% faster than the CETA standard. The concept here is that the 24-2 program may miss almost 10 to 20% of glaucomatous field defect, because now studies have shown a lot of patients with glaucoma can have early field defect in also. So in this case, what they have done, they have put central 10 degree. So basically to increase the diagnostic capacity of the visual field and also to save the time. So this is a new software, and a lot of studies are coming to show that it can give you a better diagnosis compared to the 24-2 CETA standard. So you can see here there are more points in the center compared to the standard CETA standard. So it saves times and also improves your diagnostic capacity. Thank you so much.
Thank you so much, Dr. Manish. You have so nicely elaborated everything in a very short span of time and discussed all the practical things. So may I ask the other panelists whether they like to add anything? Dr. Shashmita is there?
Yes, she's there.
Yes, ma'am.
Yeah. Do you like to ask anything or you want to add? Yeah.
Manish has covered everything in brief, I think. But very good to mention the last point that a newer version of Humphreys come out now. That is HFA3 840. And being the glaucoma, being the chronic disease, and aged patients are very, it is very pathetic to see them doing the field. They are not able to do, and day by day and year by year, the field deteriorates because they are not able to sit for a long time. So the CETA Faster is a very good option nowadays. I've been using it for last 1 month now and quite happy with it. But only thing is we have started doing with the new patients. We cannot follow up with the old patients in the CETA Faster. So that is all. I think everything he has covered very nicely. Thank you.
Dr. Sunil, you like to add any point?
I think he's covered it very well and very good practical examples. So it really helps rather than the typical boring monotonous talk with perimetry. I was enjoying his talk, really. He's done a very good job. Thanks, Manish.
Can you use CETA Faster in those patients who are already on CETA standard so that we can analyze the report subsequently?
So I was going through this. So there are some reports that mixed GPA software is now available where you can use CETA standard previously. Newer patients, you can use CETA Faster also, and they can point-to-point correlate the data. So a mixed GPA software is now available with the machine. So we can do that. We can use a CETA Faster for patient where CETA standard has already been done. In fact, I was going through an article by Dr. Anders Heil, who has worked on this software. And he has said because the time is 50% less, so in your OPD, you will be able to do many more visual fields, plus the patient performance will also improve. And they have shown that the diagnosis is at par with CETA standard. Your diagnosis capacity is not going down. In fact, you are getting more advantage in the central part. So there may be over time, we may see we are using more of this HVF 24-2C program. Over time, we may be using it more and more.
Dr. Bibuti wants to add anything?
Yeah, Manish, I want to ask just one question.
Yes,
you rightly said about the number of field which we require in patients. What about when we are following up those patients on visual field estimation? If we see a little bit of progression, then when we have to repeat it, whether immediately or day after or after a week, when do you recommend to repeat this field to confirm that the progression is there?
Generally, as I was mentioning, a lot of our patients initially will have some learning curve. So first 1 or 2 field defects we generally see to as a baseline. And over time, if we see there is a significant progression, we often change the treatment. But in case we see there is a progression, what I do generally, I repeat a field again after 2 weeks to confirm that there is a progression or not. This I do generally in cases where I'm planning surgery, not for just changing a medication. In case the patient is on maximum medication and I see there is an obvious progression, I'll often repeat after 2 weeks or a month to make sure that the progression is reproducible and I have a significant reason to go for surgery. So I think 2 weeks to 4 weeks time is good enough to see whether this is reproducible or not.
Just one point to add. This is in reference to the question which was asked, that there is this option of a seamless data transfer between HFA2, the HFA2i and the new HFA3. And like Manishda mentioned that there is this mixed GPA now. So there can be an intermixing of a CETA standard, CETA fast and CETA faster. So if you have an older CETA standard field, you can do a CETA faster and you can compare them with the GPA. So that can be done. So that is a new way. And one observation that we have found in Disha is that the patients find the HFA3 to be more comfortable. I don't know why, because there's no change in background luminance or anything, nothing is different, but the patients find it more convenient to do and the fields are coming out better. So I don't have an answer for that, why, but they are very comfortable with the HFA3 and the fields are coming to be very neat and clean, very nice.
So I just want to add only one point. While just interpreting your visual field, your right field should be on the right side and your left field should be on the left side. So that we'll not going to miss any neurological things. Once we would use it separately, better to do that thing. Keep your right field on the right side and left field on the left side. Okay, thank you so much. And I just like to call upon Dr. Arijit to call our last speaker. Dr. Arijit.
It gives me great pleasure to introduce our last speaker, Dr. Prafulla Sharma. Sir has undergone glaucoma training at Shankara Nethralaya, Chennai in 1994 and Moorfields Eye Hospital, London in 2001. He joined Sri Shankaradeva Nethralaya, Guwahati in 1994 and has worked as the head of the department in glaucoma till December 2020. He has recently joined private practice in Guwahati at Prime Eye Care Center. He has been actively involved in postgraduate teaching and training of glaucoma fellows for more than 2 decades. He is the author and co-author of several articles published in national, international journals and several chapters in different books. He is the life member of the Glaucoma Society of India for more than 2 decades and has been actively involved in glaucoma education and training programs throughout the country, with special focus in the northeast parts of India since 1994. He's been the organizing secretary for the next annual conference of glaucoma, next annual conference of the GSI to be held in Guwahati, which we are all looking forward to. So I would like to now hand over the floor to Dr. Sharma for his talk on OCT in glaucoma. So we are all looking forward to this last talk. Over to you, sir.
Thank you, Dr. Arijit, for your generous words. And now in the next couple of minutes, actually, I'll be talking on OCT, optimal use in glaucoma. I have no financial disclosure to make. We all know that OCT has become the most widely used ocular diagnostic test by now, and at the same time, probably the most commonly abused one. And there lies the relevance of this presentation. Now, in the next 12 minutes or so, I'll be trying to discuss a little bit of the principles of OCT, some interpretation techniques, and at last, towards the last part of my talk, I will just summarize the irrelevance of OCT in certain situations, which actually lead to abuse of OCT. Now, OCT, there are some reasons why OCT has become the most widely used, actually, diagnostic method, because it's a non-contact, non-invasive, high-speed image acquisition, data is objective, there is a high resolution and high reproducibility. And most important of all probably is that it yields money to the to those who has the instrument. What are the beauties of OCT actually? OCT can perform micron resolution cross-sectional imaging of biological tissues. It is based on an optical principle of Michelson interferometer. It enables real-time visualization of the tissue microstructure without the need for excising and doing biopsy. Actually, it is biopsy without surgery. You can say like that. The basic principle is that when a beam of light is directed into the eye, it is back reflected from reflective boundaries between different tissues and back scattered differently from tissues having different optical properties. And this back scattered actually waves of light is captured by detectors, and the time delay is measured, and ultimately a digitized image is generated from the collected information with false color scale representing the degree of light backscattering from tissues at different depth. And thereby, we can see the color-coded image. Now, what are the different types of OCT? Current ophthalmic OCTs are actually spectral domain and swept source OCT. Time domain OCT is probably no longer in use. OCT angiography is another rapidly evolving technology, and its use in management of glaucoma is yet to be properly defined. but it's mostly in research stage only. In clinical practice, we do not use it too much. The technical specifications, software programs, and reference databases of different OCT machines are different, and these are not interchangeable. Now, the OCT can be anterior segment OCT, posterior segment OCT. Previously, the anterior segment OCT was a different unit. Now, most of the manufacturers, they actually have started providing both the facilities with the same machine. Only thing is that some additional attachments are required, and the software has to be installed at an extra cost. The anterior segment OCT has its important role, especially in evaluating and managing the angle closure glaucoma cases, especially when the angle remains closed and it does not open after even laser peripheral iridotomy. Evaluation of the cornea, filtering blades, these also can be some other uses of anterior segment OCTs. It also can be used for educating patients and convincing them to accept the treatment in otherwise asymptomatic and little hesitant, who are otherwise little hesitant to embrace the treatment like laser peripheral iridotomy. So we can demonstrate them that, see, this is the angle, your angle is very narrow, you need to undergo certain procedures, otherwise the angle closure may progress to a much dangerous stage. Posterior segment OCT is mostly used for diagnosis and monitoring of glaucoma and macular pathologies. For diagnosis of glaucoma, we study the optic disc, RNFL, and macula. Out of these, RNFL thickness assessment is the most widely used parameter in glaucoma diagnosis and follow-up. Besides diagnosis of glaucoma, actually, sometimes we use the OCT to detect if there is any cystoid macular edema or any other pathology in the macula following use of prostaglandin analogs. Now, what is the role of OCT in monitoring of glaucoma? Based on the information gathered from a series of tests over a period of time, most of the OCT systems attempt to provide software-based information, not only for progression, but also a rate of progression. However, we need to be very careful in interpreting the results, as good quality baseline images are important, and the user should always assess the test series before using this for the purpose. It is needed to remember that agreement between structural and functional progression is very poor because of the measurement variability of structural and functional tests accompanying non-glaucoma related changes like age, etc. At present, OCT progression analysis is not age-corrected. We have to remember this. OCT progression analysis cannot and should not replace the visual field progression analysis, and both are often not correlated. RNFL thickness assessment is done by different machines in different ways, slightly different ways. For example, CIRAS high definition SDOCT, it uses a 6 mm cube scan centered on the optic disc, and from there it calculates out the RNFL thickness. On the other hand, Spectralis, that is from Heidelberg, they directly measure the RNFL thickness along a 3.46 mm circular scan centered on the disc. Similarly, OptoView, that is RT view, it actually directly measures from a 3.45 mm circle around the optic disc. Now, how to read the OCT printout? All machines offer color-coded printouts, which is generated from comparison of the acquired information with the reference database. The result could be labeled as normal, borderline, or yellow, depending on the comparison of the patient's data with the reference database. But we should always try to make a habit of reading the printout sequentially. Many times, the haphazard reading may lead to false interpretation or erroneous interpretation. So this is how a typical ONH and RNFL wave analysis printout looks like. Here in the upper part, the patient's information, this demographic database will be there. Next, the patient's actual analysis information will be plotted in a tabular format. Then we see the neuroretinal rim thickness, unfolded neuroretinal rim thickness. Both the for both the eyes, it will be shown one over other, and the comparison will be made with the normative database. If the curves are on the green zone, it is normal, it is said to be normal. Then yellow zone, borderline, and if it dips to the red zone, we have a strong suspicion that the patient is having glaucoma. But of course, as I will be explaining later, we must correlate clinically. But the most important thing is the RNFL thickness curve that is plotted, both the curves are plotted against the normative database. We will have a fair amount of idea how much actually asymmetry is there between the two curves. Then bottom to that, we will see the clockwise and quadrant-wise parameters, RNFL thickness parameters that will be displayed, and we'll have a fair amount of idea how much the patient is having the defect. And we'll be able to see from the color coding that in which quadrant or in which clock we have the strongest suspicion. Unlike RNFL evaluation, optic nerve-based evaluation with OCT is not very popular because of various reasons. Actually, optic nerve protocol printouts provide some information which are often often associated with measurement errors. Optic disc evaluation in OCT actually it cannot pick up the disc hemorrhage also. So because of many other reasons, actually optic disc protocol optic disc analysis is not commonly used in OCT for diagnosis of glaucoma. Now, more interest is now on macular OCT and ganglion cell layer. Approximately 30% of the ganglion cells are located in the macula, we all know. So any glaucoma in its earliest stage, probably it may be reflected in the thickness of the ganglion cell layer in the macula. And what the scientist actually is trying to detect that the reduction in thickness in the ganglion cell layer. Macular parameter, especially the GCC, there is a ganglion cell complex, has been shown to possess similar discriminatory ability as to that of RNFL in detecting early glaucoma cases. Now, what is the role of OCT in detecting glaucoma progression? Detecting progression early is an important part of glaucoma management. Repeated RNFL assessment with OCT over time is shown to be useful for this task, provided it is used cautiously in conjunction with the visual fields and clinical findings. In case of advanced glaucoma, of course, OCT has less value for detecting progression, and in those cases, probably macular scan may be of better help to the physicians. Now, how we actually interpret the glaucoma progression with RNFL, serial RNFL thickness, thickness measurements. The software programs actually, it gives us that the patient is probably having progression or not, but we must compare clinically other clinical findings to actually evaluate and confirm that the patient is really having some progression. I will not go into details of the thick progression analysis. OCT obviously has got some limitations. It may have acquisition dependent. There may be database related errors, disease related variation may be there. There may be other ocular confounders where the results may be actually affected by the other clinical diseases. Now, what are the acquisition dependent artifacts? There may be reduced signal strength. If the test is not done properly, then the results that we get may not be that very correct. And the signal strength should be, ideally it should be more than 5. If it is more than 8, it is well and good. The best quality scans, we should always try to have. Each machine has its own signal strength value, and we should not compare with the other machines. Technical errors like decentration, eye movements, microsaccades, blinks, all this can affect the OCT output adversely. We have to remember all these things. Color code is determined by the database of the instrument. So red and green disease and both misdiagnosis as well as misdiagnosis is possible. Now, what is red disease? Due to relatively small normative database, sometimes the normal patient with normal visual field and other normal findings, they may show red in the color-coded images. And actually, we have to say, for example, in this picture, you can see the patient is having almost a near normal visual field. But if you look into the color-coded representation of the OCT printout, OCT portion, you see that the patient is showing disease. We have to remember this point while interpreting the results. Similarly, a missed glaucoma diagnosis because of OCT can appear sometimes normal. We call it green disease with a very small focal area of damage in RNFL. The actual OCT printout may appear to be normal. But if you look very minutely, in one quadrant in the left eye, for example, in this printout, is abnormal. But if you look into the average RNFL thickness, the patient is showing almost near normal or near similar RNFL thickness value in both the eyes. So we have to see every clock hour very carefully. Sometimes what can happen, the focal sands may remain marks. If we say, for example, in this patient, the average RNFL thickness is, say, for right eye 87 micron and for left eye 86 micron. But if you look very carefully, in one quadrant, in one clock hour, the patient is having actually a depressed RNFL thickness. So only average RNFL thickness value, we should not give too much importance. Sometimes the disease-related variation may be there, and it may be a confounding factor. With advanced lobes of RNFL thickness levels may fall off below 50 micron and almost never below 40 micron due to the assumed presence of retinal ganglion cells or non-neuronal tissues, including blood vessels. So in such situations, OCT we cannot use for even detecting or detecting progression also, because for diagnosis, it does not have any role at all. Even for progression also, we may not have any role in doing OCTs in such cases of advanced glaucoma. So in summary, amongst these macula and RNFL, the RNFL is the most commonly used structure in OCT analysis for diagnosis and monitoring of glaucoma. Its role may be important in pre-perimetric and mild to moderate glaucoma. In advanced glaucoma, it does not have much role, except some recent reports where we can find that the macular OCT scanning, inner layers of the macula scanning may be of help. No imaging device, including OCT, can provide a clinical diagnosis. All of these just provide a statistical result, which may come out to be within normal limit, borderline, or outside normal limit. So interpretation should always be based on clinical context, as imaging artifacts are quite common and more likely to happen in patients with tilted disc and myopic patients. In the absence of risk factors for glaucoma and normal clinical findings and normal visual field, abnormal OCT test results can merely be false positive, and we should always ignore it. OCT can aid in diagnosis, but it cannot and should not be a substitute for good clinical examination and visual field testing. This should be remembered by everybody. Thank you very much for your hearing. I have to acknowledge that various OCT printouts used in this presentation are obtained from my erstwhile place of work. Thank you so much.
Thank you, Dr. Prafulla, for an elaborate discussion on OCT and enlightened us for the usefulness for diagnosis as well as progression. Dr. Manish, would you like to add anything on this?
No, madam. Sir has nicely covered all the key points.
Dr. Bibuti?
Ma'am, he has covered most of the points, so I think. Yeah.
Dr. Shashmita?
I think Sir has done an excellent presentation. Only thing we should remember nowadays that in pre-perimetric glaucoma, it has a lot of role when we are in dilemma after clinical examination. But only thing is the GCC analysis is nowadays comes in use in those patients. So we have to keep that in mind and do not overdiagnose with OCT and keep your clinical examination at the best. That's all is the message for.
Dr. Arijit?
Yeah, I would just like to ask a question since Shashmita raised this issue of pre-perimetric glaucoma. So there are a lot of cases when everything looks absolutely okay. Clinically, everything is okay, but you repeatedly find something on OCT. So what would you do in such a case? IOPs are normal. Clinically, it looks okay, but OCTs are repeatedly showing some sort of a red disease within quotes.
I will repeatedly clinically examine these patients because actually, if I go into the comment by Dr. Susmita, the use of OCT to diagnose pre-perimetric glaucoma, actually we had a discussion on this issue, I think last Sunday, amongst the working group, where a condition cannot be conclusively used to diagnose and establish this is early glaucoma. Can we really use it for diagnosis of a condition which is yet to have its clinical manifestation? So for diagnosis of pre-perimetric glaucoma, actually use of OCT, I think it may not be a correct statement. Yes, we can use it to see whether there is any progression in future or not. It can be an adjunct only, but to conclusively diagnose pre-perimetric glaucoma, probably OCT, probably it should not be recommended.
I have a question.
I'll follow up this question clinically for any clinical evidence in future for development of glaucoma.
Right.
I have a question to you, Dr. Sharma, that in an established case where the thing you are following them up with the visual fields, do you have do you think there is any role of OCT as well as with the visual field for follow them up? When do you recommend OCT also along with the visual field in established cases of glaucoma?
In my practice, actually, OCT I use less often for judging progression. I basically use my clinical findings and visual fields, because in OCT, the structural function correlation sometimes or rather it is not very conclusively proven that there is absolute correlation with the structural and functional centers. So in clinical practice, for academic reasons, I teach the students, but in clinical practice, I hardly depend on OCT for judging progression.
Any of the panelists want to have anything to add on this particular question?
Other panelists.
Pierce, I want to add one point. Definitely, perimetry has a big advantage in assessing progression. In fact, the newer EGS guideline has very clearly mentioned that OCT should never be used in isolation for diagnosis because of so much of variability we have. If you're doing serial OCT like perimetry, again, if cost is not an issue, every 4 months you're doing OCT also with perimetry, OCT can give you an extra advantage over with perimetry, not alone. But cost is a very big factor in our practice. And one of the big problems which I have faced with OCT is that progression is something you see over years, 4 years, 5 years time. The machine keeps on changing. So what has happened, maybe 2-3 years back, we are using a different machine. Now we are shifted to an HRA, a Heidelberg machine. So again, after 2-3 years, the machine will change. So even before the disc is changing, the machine is actually changing. And it's becoming very difficult to correlate with the older machines. So another thing which I think Dr. Bibuti sir was also mentioning about the disc photograph. A disc photograph taken 10 years back also has a lot of advantage. If it is a clear photograph, if you see the disc, you can get some idea. But a 10-year-old OCT today is actually of no use. It's a totally waste. So I think perimetry definitely is the best way, because we have to see the patient in totality, and the cost issue also is very important in Indian perspective.
Correct.
So it is very clear from the discussion that in established cases of glaucoma, visual, after doing, when it is established on the visual field itself, there is not much of a role of repeating the OCTs. So if anybody has any question, or otherwise I like to just deliver the vote of thanks. Dr. Arijit?
No, I'm nothing more to add.
Okay.
I have a question to the other panelists. How often do you repeat OCT actually for an established case for follow-up? Is it a one-time test that you do, or depending on the control of glaucoma, you decide? What? Can anybody please?
I like
yes.
Yeah, please.
Please.
As in established glaucoma, actually, I also don't use OCT. I use perimetry only to see progression. There is a subset of pre-perimetry glaucomas. For example, when you are seeing the disc with the very classical glaucometers finding, you can see some RNFL thinning also. So by disc evaluation, you are very sure that you are dealing a case of glaucoma. You have a borderline pressures also, but the perimetry is normal. Those cases when you do OCT and the OCT matches with your clinical finding, it sort of gives you an extra edge to treat the patient. And these patients, when you repeat OCT after 4 months, 6 months, and on the same machine, not on a different machine, it does give you some idea about the progression. So that small subset of pre-perimetry glaucoma where you are very sure about your clinical finding, but you are not getting support from perimetry, OCT helps. Second very important thing, you are very sure that disc is normal. Perimetry is giving you bizarre reports. You want to stop medication. Sometimes you do OCT, you get all green. It sort of gives you an extra reason to stop the medication. It gives you extra confidence to stop the medication. So these are two indications where I use OCT a lot. Not much in established glaucomas.
Just one point to add. one point to add to this, to what Manishda said, that when you're using a HFA, you have the visual field analysis and you have this trend analysis where you get the VFI slope. So OCT also in GPA, it gives you a trend. So probably if you do multiple OCTs, even in an established case, you can get a trend as to how the RNFL loss is progressing and compare it with the visual field loss. So that can be one kind of case scenario where you can do it.
Thank you. So last but not the least is a vote of thanks. So I thank you all for participating in today's webinar and making it so successful and interesting. So my special thanks goes to all the national faculties who just spared their valuable times today, namely Dr. Shashmita Das, Dr. Manish Singh, Dr. Prafulla Sharma, Dr. Bibuti, and Dr. Sunil Jin. Thank you all for sparing the Sunday's evening and staying with us till this end of the discussion, because you were the panelist only. So I would like to thank my co-moderator, Dr. Arijit Mitra, who has diligently prepared all the questions and giving me confidence also. Thank you, Dr. Arijit. And I would like to thank the sponsor, Santur Pharma, for continuously supporting us from the back office. And that's why our program was so smooth. And my special thanks goes to Mr. Hitendra Punmiya, the brand manager of Trabeculectomy, for very quick and smooth conduct. Thank you, Mr. Hitendra. And last but not the least is our audience. I would like to thank you all for your valuable presence and making our program so successful. So thank you all and hope to meet you soon. Good night.
Thank you. Good night.
Good night.
Thank you. Good night.
Good night.
Madam, for nicely conducting the program and inviting all of us.
Thank you. Thank you,
Maitri.
Thank you. See you all. Bye.